Today's episode has been brought to you by Schedulicity.
Welcome to episode 75 of the Connected Yoga Teacher podcast. Today, we welcome back Dr. Sinead Dufour, pelvic health physiotherapist, researcher, and teacher at McMaster University in Ontario, Canada. Sinead talked to us back in episode 33 about diastasis recti. It was actually one of the most popular downloaded episodes to date. And so I will make sure to include a link to that podcast in the show notes. If you've never checked out the show notes before, I get it. I listen to podcasts on the go, and it is difficult to remember to go back to the link and look at it, but I will tell you that our show notes are really complete. They're kind of like a blog post in every one. So Laura goes through and does a summary of the main topics with clickable timestamps. So if you just want to hear about one topic, you can go back and click on that timestamp. So go to theconnectedyogateacher.com where all of the show notes are there for you. It is worth checking out on a day when you are at your computer. You can also click from your podcast app that you're listening from as well, and the show notes should be in there also. Especially today's episode for the show notes because I share a symmetry sequence that was designed by Cecile Ross and Dr. Sinead Dufour, and I use this sequence all the time in my own life for my own body and with many of the yoga students that I work with. It helps to really strengthen, it's symmetrical, it's an amazing sequence. Also, Sinead shares some other poses and just to help students who are dealing with pelvic girdle pain through different movements, and a study that she refers to in today's episode. So today's show notes are at theconnectedyogateacher.com/75. That's all you have to really remember for each episode is the episode number. How are you doing this week, Connected Yoga Teachers? How has your week been? And if you're listening in real live time, how has your July been? How has this month been for you? So in Canada here, we're into summer full swing. I feel like my schedule is all over the place. I've just really been trying to focus on what's the one thing that I can do today on top of everything else. I get really wrapped up with fun with the kids. We've been on holidays. I've been away from my email and away from Facebook a little bit more. I've been trying to check in with our Facebook group for sure. But I want to hear how your time is going. If it's summer for you, how's that going? How is it affecting your yoga business? For those who don't know me already, my name is Shannon Crow. I'm a mother of 3, a yoga teacher, and a consultant for yoga teachers. I get how isolating it can feel as a yoga teacher and an entrepreneur. I remember how I felt after my first 200-hour yoga teacher training. Sort of like I had been dropped into this wilderness of yoga learning with just a small idea of what yoga was. I believe that when yoga teachers create a sustainable business, we have more consistent yoga in the world. I want to see yoga teachers generating profit so that they can afford to take more training when they need it and want it and continue to teach. I'm not afraid to dig into the money mindset issues that hold many of us back as yoga professionals. I also believe that each yoga teacher has a unique offering that no one else can replicate. This is their yoga niche, and while it is all yoga, this is what sets your yoga apart and helps students to know that you are the teacher for them. The Connected Yoga Teacher podcast was created for you, the yoga teacher entrepreneur. Every week between the classes, workshops, and trainings that you are teaching or attending, you can connect here to information, ideas, and a supportive community of other yoga teachers. A supportive community is really a big thing in my life, and I think it's so important to yoga teachers overall. If you're not already a member of the Connected Yoga Teacher Facebook group, come over and join us. Visit theconnectedyogateacher.com and look for the join button on our homepage or follow the links in the show notes. As of today, as I'm recording here, there are over 3,000 yoga teachers in that group from around the world. And our main rule, the main focus, the main goal is to post questions, ideas, inspiration, challenges, and information while at the same time really supporting each other. supporting each other as yoga professionals in that group. And that means that we go through the comments, and if they're not helpful and they're not supportive, those comments get deleted. And if someone continues to post things that are not helpful and not supportive, that person gets deleted. So it's a safe space to ask questions. For sure, we all have different opinions. For sure, we sometimes say things and then learn from them. I don't even want to call it a mistake, but the overall general feeling in that group, and I'm so glad to be a part of it with so many amazing teachers, is that we're using the principles of yoga in our communication with each other. Before we dive in today, let's hear from our sponsor, Schedulicity.
Hi, Connected Yoga teachers. This is Chelsea from Schedulicity with a hot tip of the week. Schedulicity's package management add-on is a great option for yoga teachers. This allows you to create an incentive package with a discount that can add value to your students' visits and help ensure their return business. If each one of your classes costs $10, you could create a 5 for $40 package and offer it online. Then, when your clients are booking a class, they'll see this option. Payment is required upfront for packages, so you'll be paid and they'll have a great reason to come back. Maybe one 5-class package is all they need to turn their yoga practice into a habit.
Thank you so much to the entire team at Schedulicity, not only for your amazing online scheduling software that I use and have personally used since 2011, but also for being our podcast sponsor so that this episode is shared out with the yoga teachers around the world. Thank you for that, Schedulicity. If you want to hear more information about who Dr. Sinead Dufour is, make sure to go back to episode 33. So go to theconnectedyogateacher.com/33. Because Sinead has so much to share in this episode, we're going to get right into the topic today on pelvic girdle pain. If you're not sure what pelvic girdle pain is, Sinead's going to go into that right away. But we basically look at the area under the rib line all the way to where the glute muscles end and the leg begins. So the entire pelvic area and a bit of the lower back here is included. So we see a lot of yoga students coming to class talking to us about pelvic girdle pain, even if that's not what they're calling it. They may be coming in saying that they have symphysis pubis dysfunction, sacroiliac dysfunction, SI joint pain, low back pain. Research is now showing us that 70% of women have pelvic girdle pain in their second pregnancy. So for those of you working with anyone prenatally or postnatally, you're going to start to see this show up more in your classes. And about 20% of the population roughly has persistent pelvic girdle pain. So this is continuing on beyond into that postnatal stage. At the end of today's interview, I'm going to be here just to summarize some of the main considerations when you're working with yoga students who are dealing with pelvic girdle pain. So let's dive in and hear from Sinead again. Welcome back to the Connected Yoga Teacher podcast, Sinead. It is fantastic to have you back.
Thanks so much, Shannon, for having me. I'm excited to be back.
This is a first. We've never interviewed someone who's been on the podcast, so you're the first return guest. And I'm really excited because you covered before, if anyone didn't hear you covering diastasis, you did such an amazing job with that. We had such good feedback from yoga teachers, Pilates teachers, physiotherapists. I feel like a lot of people said to me, I got so much information from that, and I still send it out. And what I'm excited about today is that we're going to dive in, talk about pelvic girdle pain. And I feel like this is another one that really catches yoga teachers and almost makes them feel like, you know what? I don't want to teach anyone who has this. So please don't come to my class, which is impossible because it's really prevalent. So education is really the key. And so I'm excited that you're here with us to chat about it. Can you tell us what pelvic girdle pain is first?
Yeah, so pelvic girdle pain, it's interesting because as you'll hear me discuss really what this issue is actually about, particularly with women who are pregnant, really you're going to hear me talking that it is really a lot less about the mechanics. But the interesting thing is how pelvic girdle pain is defined. It's defined by mechanics. So, similar to those of your listeners who heard me talk about diastasis, is part of our problem in managing the darn thing is actually relates to how it's defined, and the name of it is a bit of a misnomer. And I would say in a way the same issue is at play with pelvic girdle pain. So pelvic girdle pain is actually defined anatomically. It's defined as pain that sort of starts under the rib line and then goes below the gluteal fold. So basically that whole center area is referred to as pelvic girdle pain and differentiated from back pain or radicular pain that's usually a part of back pain, right? So it's defined anatomically. Pregnancy-related pelvic girdle pain is pain, again, within that anatomically defined region, right? Pain that presents in that region when you're pregnant or in sort of the postpartum within a year. So any time pain in that region presents in that time frame, it's often subcategorized as pregnancy-related pelvic girdle pain.
Okay. Thank you for clarifying that. So
there's our definition.
Yeah. And are there some names that it used to be called that people might have thought, oh, I've heard it called this, or I have this?
Yeah, that's a great point. So, we now kind of have it more of this sort of umbrella term, which I would argue is more appropriate than some of the previous terms that were symphysis pubis dysfunction, for example, has often, if you look at all the studies in the literature, there's many studies that are indicating they're talking about symphysis pubis dysfunction, which of course the symphysis pubis is actually at the front part of that pelvic girdle. But really, when you read through, they're referring to pelvic girdle pain because, what we actually know is that issues or damage to the actual symphysis pubis, which is a really strong cartilaginous joint, actual trauma or damage to that joint is incredibly rare. But sensitivity and pain in the region of that joint is a very common presentation of pregnancy-related pelvic girdle pain. So, this is one of the pieces too that a lot of women will present with kind of pain in that region, and many individuals have an understanding of pain in that region has something to do with something wrong with the symphysis pubis joint. And some of that is because, that is how they've been taught. And there is sort of some literature that's misguided from that perspective. So that might be one term. Another term that people might hear is sacroiliac dysfunction. Right? So the two sacroiliac joints are on the back of the pelvic girdle. And so again, we can have sort of pain manifesting or sensitivity manifesting in the region of one of the sacroiliac joints. And then it can kind of be referred to as, okay, this is a sacroiliac joint dysfunction. But really we've moved to kind of term it pelvic girdle pain more globally. And as you're going to hear me try to mount an argument as we go through this conversation together is, I think it's okay if people are understanding, that they're identifying the region of the pain, but really understanding that we're not talking really about a mechanically mediated problem. There are mechanical impacts to the problem, but it's not really driven by the mechanics.
Okay, this is good. So often I get this question in prenatal yoga teacher training or in prenatal yoga classes. We've heard that different pregnancy hormones, we're not sure which ones they are, or I'm not sure which ones they are, contribute to an increased laxity in the pelvis. And then I see students coming in saying, I feel like my pelvis is coming apart, or I feel like it's moving too much, it's becoming too lax. And so what I hear you saying is there is that sensitivity. We do have to very much listen to what they're saying. But I also hear you saying that I'm going to let you get into that because I kind of know your opinion on this, and I feel like you brought this light bulb moment when you were talking about the strength of the pelvis.
Right. So, yeah, you're quite right. And this is the same type of issue that physiotherapists, would face also, right? So really, what do we know right now, and kind of what have we known and how has that evolved? Because that might help people to kind of understand and reconcile kind of maybe previously what they thought, and then better understand really what's probably happening as far as we know. So, I mean, we certainly do know unequivocally that the pelvis structure is one of the strongest places in our body. So, yes, there has been some studies and some thought to indicate that, yes, a variety of different hormones, relaxin being sort of one of them, do impact these tissues of the pelvis, and quite logically to allow the ligaments to be a little bit more malleable to allow for a baby to come out of that space, and that kind of makes a lot of intuitive sense, and that seems like it's a really good design of the human body. And certainly studies have corroborated that, yes, relaxin, and that's why it's named relaxin, because it relaxes the ligamentous structures, right? So yes, we know that. But what we don't know is, does that increased sort of laxity of the ligaments translate to any type of pain or hypersensitivity? That has actually been an assumption, that connection, right? And so certainly from the perspective of the most recent clinical practice guidelines on pregnancy-related pelvic girdle pain were just actually published last year in 2017. And in the review of all the literature that needs to be done to produce a clinical practice guidelines, which is an enormous amount of work for anyone who's been involved in that process, has indicated, yes, there is no evidence from everything we've checked to indicate that increased relaxin relates to pregnancy-related pelvic girdle pain. That's not to say increased relaxin doesn't increase the laxity of the tissues, but it's just to say we can't assume that laxity of the tissues translates to pain. Because arguably, if relaxin relaxes the tissues, then relaxin is going to relax everyone's tissues. But everyone doesn't get pregnancy-related girdle pain. So there are other things that are mediating the physiology that end up with that pain output, right?
Yeah.
So then some thinking has been, okay, well, maybe it's not this concept of, too much relaxin, too much movement in the structures that's causing pain. Maybe it's that we're getting asymmetrical movement in the structures, and it's the asymmetry rather than just too much global movement that's the problem. And this was a theory that, again, made a lot of sense. Certainly when as physiotherapists or yoga instructors, or those of us who do this work, would try to actually promote better symmetry within the pelvic region, it would seem that people would do a lot better, right? So again, that kind of, helps to substantiate, okay, so maybe that's more of the issue, is that we can get a little bit more movement in the pelvis, and then that makes it more likely that we're going to have slightly asymmetric movements, because of course we have two joints at the back that aren't going to necessarily move symmetrically, right? We tend to move with a rotational bias with everything we do, right? And sure, maybe there's some truth to that. That is really yet to be proven. But what newer research has shown in 2015, an interesting, really comprehensive study was done that actually highlighted that women who are pregnant actually have higher sensitivity in their tissues, particularly around the pelvis, but actually everywhere, than non-pregnant counterparts. There's just this generalized hypersensitivity with all women who are pregnant through that period, regardless of what kind of mechanical test is done. And so then from there, some pain science researchers have explored that further and said, okay, well, if we know that what's happening in pregnancy is making people their tissues a little bit more sensitive to begin with, there must already be some things happening in those who just have that extra sensitivity that end up with this pregnancy-related pelvic girdle pain. And some of those factors that have been established are having a previous pregnancy, but particularly having a previous pregnancy that any aspect of the pregnancy or delivery were perceived as traumatic in some way. And we can appreciate when we understand, sensitization of the system, we can appreciate that type of a precipitating event would sort of sensitize the pelvis to a certain degree, but maybe you're not going to notice it until you're pregnant again. And then your system is a little bit more sensitive from the pregnancy, but now it's been sensitized from the last one. And lo and behold, you end up with this issue. And, certainly in my practice, this evolved understanding seems to line up with what I see all the time. So, I certainly have been really happy that a lot of the science coming forward is pointing more to what we would call central mechanisms of this pain or sensitization process, rather than focusing on these mechanical factors. Because actually then when I'm addressing, the women in front of me more from the perspective of those central mediators, actually she gets better immediately. Right? So it works.
So tell us how that works. So if we're letting our yoga students know your pelvis is strong and sturdy, it's one of the strongest places in your body. It's not falling apart, but acknowledging that the sensitivity is there, that there is something to that sensation. So letting them know about that. And then also I'm curious about the asymmetrical, because in yoga, that's one of the biggest focuses that we do with pelvic girdle pain. We just think, obviously we can't be symmetrical all the time. Like you would say walking isn't truly symmetrical. You need to move one leg and then the other. So is there anything to that? Do we need to still consider that symmetry?
Absolutely. So what I think is important for people to understand is what's really at the root driving the problem, but then what are some other secondary kind of mediators of the problem? And I would argue that kind of moving around with these really obvious asymmetrical patterns is definitely going to irritate an already sensitized structure. So of course we want to deal with that, right? But I think if you're only dealing with that, but missing some of the main drivers, your treatment can only go so far. The assistance you're trying to provide this person can only go so far. So, really it's what you actually just said, Shannon, is helping people to understand, look, yes, the sort of discomfort and disability you're experiencing is totally legitimate and real. And the good thing is we actually now have a pretty decent understanding of why that's happening. And there's actually a lot you can do to fix it. So one of the first things, though, that people can do to fix it is actually make sure their belief system about what's happening is accurate and is constructive. And unfortunately, by the time someone's come to me, and perhaps this is even the case by the time they've landed in a yoga class, which actually is one of the best places for people with this problem, and I'll explain why in a minute, they have either been told by other very well-meaning healthcare professionals or other well-meaning friends that, oh yes, what you have a lot of instability in your pelvis, and you just need to be really careful with how you move, and you have to make sure when you get in and out of a car, you just keep your legs really close together. And all of these very outdated traditional sort of concepts that, one, are very fear-mongering, two, completely undermine the sort of stability and power and resilience of the pelvis, and three, actually set up a lot of sort of dysfunctional fast-forward mechanisms, because if a woman's being told that their pelvis is unstable and they actually need to move in a way that holds it together, what on earth do you think is going through her head when the reality is she has to birth something out of there in a few months?
Right.
Right? So that in and of itself really sets up a cascade of further sensitization, right? So, really setting the record straight of, yes, your pelvis is totally strong. You might have heard some misguided information, X, Y, and Z, but actually your pelvis is fine. And what's probably triggering more of a pain output actually is a guarding and protection mechanism. And actually, if we can let the pelvic floor go and we can move with ease, and within that kind of do things that are less likely to irritate a sensitized structure, you're going to do just fine. So one of the things I'll often tell clients is I'll sort of use the example of my own two children who are twins. And I will say, so I have twins, and, my children are very different. And my son is just a more sensitive person. He's just more sensitive. So if I want to get both my daughter and my son to sort of do the same task, I actually have to approach it a little bit differently with my son, or else I'm going to get a reaction, right? So I do it differently. I know he's a sensitive child, so I handle him a bit differently, but I can still get the same thing done. It doesn't mean there's something wrong with him. It means he's a bit sensitive. It's the same thing with your pelvis when you're pregnant and you're having this pain. It's sensitive. So it doesn't mean there's something wrong with it. It doesn't mean it physiologically isn't going to perform the way it needs to, but it is sensitive, so you're going to do differently. You're not going to keep irritating it to get a reaction. You're going to do differently. So what might that look like? Well, there's different ways I often teach people to get from a standing position to a lying down position in a way that's going to irritate the pelvis less. I often will tell women that a sensitive pelvis, and I'm very careful to always use the term just sensitive. It's just sensitive, right? It's strong, it's robust, it's healthy, but it's sensitive, so it's going to be a bit reactive, right? So a sensitive pelvis doesn't like standing on one foot. Sensitive pelvis actually hates that. So again, when we're getting dressed, we're always going to make sure, we're sitting down first, we're putting our legs in our pants, we're getting ourselves set up in a more optimal way to propel ourselves up in a little bit more of a symmetrical way. And we're not trying to stand on one foot to get dressed. So that's, I'd say, where the symmetry piece comes in. And it's a really important piece because doing these asymmetrical tasks are triggering for a sensitive pelvis. But what I would say is the more important underlying concept is for women to understand that a lot of this bracing and tension and really these protective mechanisms that are at play, we need to be aware of those and let those go. We need to trust our pelvis. We need to be sending sort of signals of reassurance and resilience and safety to our pelvis. And actually, when I engage in this approach, women often, I will see them, they will come to me with this problem. And many times when they come to see me, they're debilitated. They're using a cane. They're in a walker. They've heard of me from other places, and they walk out of my office completely fine. And I don't see them for 6 weeks. And they're like, I can't believe it. I'm totally fine. And really, I haven't done much mechanical things at all. Right? So in my physio training before I really specialized in this, I was an orthopedic physiotherapist who had tons of credentials and very fancy manipulative hands-on work. And so, before, how I would have handled pregnancy-related girdle pain is with a lot of manual maneuvers and manual techniques. And sure, sometimes that helped a little bit, but I never got the results I got now. And at the end of the day, the woman then has the idea in their head that they're dependent on me. Right? My approach now, I can explain to them what's happening, the power that they have. Usually there is some tension in the pelvic floor implicated. So of course I have the benefit of assessing that area and making the woman really aware of that protective mechanism. But really, I don't think you need to do internal work to make someone aware that their pelvic floor is guarding. I think there's a ton that yoga teachers can do to help people be aware of that and let that go. And, that has really, really made a big difference. And certainly where the evidence is going on that really corroborates this perspective.
Right. So I know if someone comes to a yoga class with me and they tell me that they're having any pain in the pelvis, anywhere in that area, I refer out to a pelvic floor physio and let them know, I have experienced pelvic girdle pain, and going to see a pelvic floor physio really helped with that. And so we can be giving them the empowering message. We can also be looking at symmetrical. So I know you helped me. I feel like it's through Cecile Rost and then you, and then there's a pelvic symmetry sequence. I am happy to link to that. I do know in that, it's not one size fits all. It's a pelvic symmetry sequence that works really well. And then there are always modifications working one-on-one with someone.
Absolutely.
And you said I think two other things that I've learned from you are the sit to stand and also the lying down.
Yes.
Do you want to describe those, if we can, through audio?
For sure. So, certainly, and I do have a little bit of a descriptor and an image of that I'm happy to send you, Shannon, and then you can maybe make it available to your listeners. Sure. And these are all, as well as the symmetry sequence sheet that you put together based on my modifications to Cecile Rost's kind of original symmetry. these are all resources I give all my patients, right? So as much as I want to make sure people leave my office with the understanding that their pelvis is strong, it's just sensitive. In fact, it's a little bit overprotective, because usually as I've kind of unearthed through our discussion, it has come up that, yeah, this is their second pregnancy. So this is something you'll see much more often in the second pregnancy, right? The literature confirms this, and this is what I see in my practice. And actually, in every single practice guideline, one of the established risk factors for this problem is a previous pregnancy. The problem is a lot of studies look at the what, but not the why, right? But it's like, but not everyone who's had a previous pregnancy gets this the second time around. So it's like, why? And you know what a couple of studies have deduced is that it seems like if something kind of traumatic has happened that first time, then you're much more at risk. And that's certainly what I see. And so, you know, and oftentimes it's not even a really obvious trauma. You know, what I've actually experienced is many times as I'm saying to a woman, because they're coming to see me and they're frustrated because this is my second pregnancy. I didn't have this before. I don't know what's going on, but it's really interfering because here I am, I'm trying to deal with my toddler and I'm pregnant. And so, you know, I'll kind of talk to them a little bit about, I'll say, you know, let's talk a little bit about your first pregnancy and your first birth and that recovery time afterwards. And either 9 times out of 10 or 10 times out of 10, we're able to pick up a couple hiccups there that maybe even she wasn't aware of. And often as we're talking about that and I'm explaining to her, you know, this in and of itself could be why your pelvis is being a bit protective. Because even if you're not sort of consciously recognizing that it was a trauma, your body does. And your body's like, here we go again.
Oh, I love that.
Here we go again. And so if you can kind of understand that, and I'll say, and oftentimes too, when you're pregnant the second time, you aren't getting quite as much rest. You've gone into the pregnancy more depleted because you already have a child. You know, you're often doing things mechanically that aren't the driver of the problem, but are mediating the problem. That you weren't doing the first time because you have a toddler that you're worrying about, right? So there can be all sorts of things, but certainly these are all pieces that I will dialogue with an individual kind of the second time around. So it's kind of about this trauma. So again, just coming back to the mechanical piece. So I want them to understand the driver isn't the mechanics, but the mechanics are relevant. And the mechanics is something that they can have a lot of control over. Because while I don't want them to be afraid to move, I will say I want you to move mindfully. I do not want you to fear movement. I don't want you to be afraid to try anything, but I want you to be mindful about what you're doing, understand that your pelvis is a little bit sensitive, and then when you do something that your pelvis tells you, you know what, that was aggravating, be aware of it so you can do differently next time, right? And so I have had many clients say, and this is before I have even done an internal in them, and I do have some clients who don't want an internal. They are just in too much pain. They can't move. They're freaked out. Maybe they acknowledge they had a really bad trauma the pregnancy before. Maybe they acknowledge that the pregnancy they're having right now was an unwanted one. That's another really common time that we see a lot of pregnancy-related girdle pain. And it makes sense, you know, when you really understand what that issue is all about, because it's really not about the mechanics, right? And so, you know, just even going through empowering someone how to move in a way that's not going to tick off their pelvis really does a lot of work. So yeah, certainly if it comes to going from a standing position to a lying position, we do want women to avoid common things that would irritate a pelvis. So certainly doing like a reverse type of a sit-up just to kind of lie down, that tends to be pretty compressing and irritating on the structures of the pelvis. And if it's already sensitive, it's not going to like that, right? That also, depending on the stage of pregnancy that you're in, usually isn't great for the linea alba either, right? So there's more than one reason why that's probably not a great way to move. And every single time a woman moves like that, because usually in my office, I will say, okay, I'm going to have you come over to the table and I'm going to have you just lie down and I'm just going to watch to see how you choose to execute that task. And, most times a woman will come over, she'll kind of haul both her legs up on my table and then do a reverse sit-up back. And I can see her wincing as she's going back, and I can see her belly doming, right? And then I would say, okay, how did that feel? And usually she'll say, well, yeah, see, like my back hurt. Like that's kind of what I'm talking about, what I came to you for. And I'll say, yeah, and I must say I'm not surprised because moving in that type of a way is irritating for a sensitive pelvis. So I'll say, I'm going to take you through a way of moving that usually is much less irritating for a sensitive pelvis. And really then I will take them from supine back up to standing, and then I will let them go back down again. So, when you're supine and you're getting up to standing, how it works best, and this will be sent to Shannon for those of you who want to see this or use it as a resource, we really suggest that one leg is lifted up and the other leg is out straight. And that the side that the woman would be rolling towards, that's going to be the side that the leg is straight. So the leg that is up, it's bent up enough that a woman feels like if she was to push through her heel, she'd have decent enough power to be able to get some type of lift, because the idea is you are going to move from that position then onto your side, right? So exactly where that foot will be positioned will kind of depend on the woman's own mechanics, but usually it's approximately where the foot would be for bridge pose, right? It's approximately in that position. And similar to bridge pose, we don't want the hip moving into internal rotation. We want it neutral. So same thing when you're doing this. You want your hip in neutral or even slight external rotation. But the tendency is always for the knee to drop in and the hip to drop in. And when that happens, that aggravates a sensitive pelvis. Right?
Yeah.
So it's a matter of watching that piece. I often will have them kind of push through their heel as they exhale. So then you're kind of coordinating it with some type of engagement of the deepener unit. So then they'll exhale, they'll come over to their side. Then they're lying on their side. And again, we want to give them the best mechanical advantage so they're not irritating a sensitive pelvis. So then I'll have them move their hips up into like 90 degrees flexion. So they're mimicking more of a seating position even though they're in side lying. And then again, as they exhale, they're going to use their arm that's on top to exhale, push through their arm to get their upper body up, drop their legs off the table at the same time so gravity kind of pendulums them up, and then they're in seated. And then from seated, I'll have them sort of slide as forward as they can on whatever surface they're sitting on so that their feet can touch the ground. I will have them lean their weight forward, have the balls of their feet actually behind their knees. So again, they're just in a more mechanically advantageous position. If they have a tendency to sort of sit on their sacrum, this is a nice opportunity for them to sit on their sit bones and get off their sacrum and tailbone. And then again, as they exhale, I'll have them push through their fingertips into their thighs and kind of push up into standing, because again, that's going to sort of activate the core system. And usually when someone's gone through this process, they're almost gobsmacked by just how much easier that was. And then I'll say, and essentially it's the exact reverse to get back down, right? Mm-hmm. And I'll allow them some time and space to sort of do that. And so I've had women like walk out of my office, and just between that and the symmetry sequence that will be posted, and just them feeling a sense of relief that there's not something wrong with their pelvis, they walk out. And, as I said, many of the clients seeing me have come in with canes and walkers, and they walk out fine. And they're just like, oh my God, that's amazing. And some of those people are people I didn't even touch their pelvic floor, right? So yeah, these basic principles just are so simple, but so powerful. Another piece is, this whole concept of cortisol being high. Researchers in Cork in Ireland, who I've just actually started working with, did a pilot study showing they were basically trying to highlight that the mechanical approach done by the physiotherapists in town, and this is in Cork, Ireland, really wasn't working. And that from their perspective, because these are all researchers at the Microbiome Institute at Cork, from their perspective, they see these types of pain syndromes more mediated by high cortisol. And actually did more of an approach on educating about cortisol and pain science and gentle movement that shouldn't be feared, and found that not only did the pelvic girdle pain get better, but it actually got better in correlation with how the cortisol levels were coming down.
That's amazing.
Right? So I think we need to really just kind of change our approach, knowing that the mechanical piece, absolutely, it has relevance, but the other piece is more important. And to me, nothing helps to balance out that autonomic nervous system more than a shavasana. Right? So, to me, like women to be engaging in a prenatal yoga class where they're getting social connection with other women, they're having some time and space and connection with their baby, they get to engage in different postures, which are going to help to kind of develop flexibility, maybe in structures that have been tight and guarding and are overprotective. And then they get to be in a shavasana. I mean, what better thing I would say for anyone, but especially someone with this problem, right? So, yeah.
That's amazing that we can provide that in a yoga class, and all of those elements are there. Like you said, lowering the cortisol. I really appreciate your language around this, that it's a sensitive pelvis and also a protective one, because the other language that I hear so often is it's dysfunctional or it's falling apart. And there are even different things that I have seen people really, I don't know what it's called, but tying the pelvis up, like giving it a little more stability. And it's almost gives a sense of like, I can't hold this together. Something else outside of me has to.
Right. Yeah, that's called a sacroiliac joint belt, or, a pregnancy C belt. And again, you're quite right. I mean, the evidence to support the efficacy of these is really low. It's level D evidence, and evidence when it's graded, from that systematic perspective, it's A, B, C, D. So D is pretty bad, right? And I mean, certainly it makes a lot of sense now if we sort of understand the output of pain to be related to what we've just been talking about. It makes a lot of sense that why on earth would that help? Like, we're more often dealing with structures that are already on too much, and structures that are on too much don't work well, right? A muscle that's too short can't function, right? Muscles function on a length tension relationship. So, not only are you going to have some pressure on mechanoreceptors that might trigger a pain response from the excessive tension, but the muscle in and of itself can't do what it needs to do. So you arguably will have less coordination, and you will maybe have less power generation and weakness, and you'll have all these other things, which also could fuel the fire for the pain response, right? So yeah, I tend to be, if someone comes in to see me, they have the pelvic belt, they've gotten it, let's say, from their chiropractor, and, I'm never going to be able to get them to reconcile their beliefs about what's going on because it's a bit too entrenched at this point, and I just don't have enough time until they have their baby. I will certainly do what I can about hopefully getting them to develop some type of a sense of a trust in their pelvis, at least kind of when they're lying down and not moving. If they are clinging to the belief, well, no, I just need this for when I'm walking, or I just need... Sure, if I'm not going to change their mind, I don't want to take that from them, but I at least want to get them doing the symmetry and opening up their pelvis in supine, and maybe if they feel safer in supine, and at least getting them trusting their body in that position so they have some availability in supine or side lying or some type of a supported position that they feel confident birthing that baby in, right? Because, again, while, this issue is common, I mean, some of the research shows that it's up to 72% of people in their second pregnancy have this problem.
Wow.
So it's high, but, and so I would argue this whole thing needs to be addressed better. And I think if it was addressed better, people could probably birth better because they're not going to be scared to birth, and then they'd recover better. But the biggest hiccup to me is that 20% of the people who have this problem, they go on to develop persistence of this problem beyond 1 year postpartum. And to me, that's the biggest travesty, because that's now going on and on and on and on, right? And I think those are the people who really this mechanical approach was really misguided for, and now they're really stuck. And those are definitely the ones that I think we need to do a much better job with.
So are these the people that we're seeing years later that are saying, I have SI joint pain? Or are those the one like the sacroiliac joint pain? Is that also?
Yeah, I would say, I mean, this is certainly from, so the degrees of persistence in the studies varies. It's as low as 7% in some studies and up to 36% in other studies, but it kind of averages out around 20%. And this is probably what I would say I see in my practice. So, these are the people that, we might even say 2 years later to be like, I just had this kind of pain here. Had it when I was pregnant. I kept being told, oh, don't worry, that's normal. It'll go away after you had your baby. And then it never did. Right.
Wow.
And I would say, well, part of the problem there is you were misled to believe it was a mechanical problem that would change when the mechanics of your body were different after the baby was gone. But we know it's actually in most cases not a mechanical problem. So there was probably other features there the whole time at play that no one addressed. Yeah. Right. And so, again, when we apply all the same things we apply for persistent pelvic pain, we can get these ones better, but it usually requires someone who knows a lot more about persistent pain to get them better. Right.
Okay.
Whereas I would say if people are seeing a yoga instructor while they're pregnant, who all they knew was the knowledge from this podcast, they could prevent a big problem.
Right.
Right? It's
just
a lot
with
easier.
The language even.
Exactly. Just with what we talked about today, they could probably have that woman have a better pregnancy, a better birth, and not have persistence. Whereas once we're in that persistence, then, it's not to say that we can't change it. We absolutely can, but it does require, I think, a different degree of knowledge and understanding and kind of ability to have more of a therapeutic alliance with someone over time, alongside with a lot of in-depth knowledge, because it oftentimes means actually deconstructing some really firmly held beliefs that are not constructive, and then replanting a garden of more appropriate constructive beliefs. And it does require someone to really trust you as an expert, often, to be able to make that shift, right?
Right.
So it does. It gets trickier then. So those are the 20% of women that, I think I feel the most frustrated about. But I think globally, as a care community of fitness providers and clinicians working with women, if we could just have a bit of a basic understanding of how to deal with this issue in a more constructive way, we could be doing a lot better.
So a couple of questions. One is, I think I heard you say that pelvic floor is usually hypertonic, or muscles are really tight in the pelvic floor. So obviously then if someone was told, oh, after you have your baby, make sure you do your kegels, this would aggravate it even more then. Am I assuming that correctly?
Yeah, I mean, it certainly could if sort of whatever the protective mechanism that was going on during pregnancy, and maybe that was related to a birth trauma from before, and maybe if the second birth is actually okay, after the birth, that protective mechanism goes away, right?
Okay.
It's like, it's over. So I would say maybe, but maybe not.
Okay.
I would certainly say making sure the pelvic floor is pumping well, even through the pregnancy, is actually a good thing. But having a pelvic floor that's pumping well alongside the diaphragm to really capitalize on the lymphatic flow is different than Kegels. Kegels are sustained holds, right? And Kegels certainly have a place with certain problems, but Kegels are different than what I would call the core breath. They're totally different, right? Yes. So I would say we always want to get a protective response out of the tissues to the point that we can get the core breath going. Always, that's a goal. But it's a very small proportion I see of people that my goal is actually to do a full-on protocol of pelvic floor muscle strengthening. Some patients I want to do that with, but not all. Right. The majority, I definitely, we want to get the tension out of our structures, but we still need to get that tissue activated and pumping. We just need it to do it constructively, right? And, we have a lot of evidence to show that when a pelvic floor is fit, and I don't just mean strong, but when a pelvic floor is fit, births are better. Second stage is better, right? Even a systematic review just came out 2 weeks ago that confirmed that again. So just because someone has sort of a protective response in their pelvic floor doesn't mean I don't want their pelvic floor fit. I do want it fit, but it can't even come close to developing fitness if we don't get the protective response out of it. So that's always my first, that's my first line of attack.
Right.
And then the second one is, getting the pelvic floor going.
So that leads right into my second question, I always feel like that's my go-to place is this referral out, because I can provide, the shavasana, the breathing, the core breath for sure, different poses, the symmetry sequence, and pieces of education around this strong pelvis that's sensitive or protective. But then it gets to the point where I don't know what's happening with someone's pelvic floor. And it's so nice to be able to refer out to a pelvic floor physio for that. I guess my question is, at what point can we not? So I refer all the time, all the way through pregnancy and postnatally, but I think some people are thinking, oh, that's just something I can do after I have my baby. Do you want to clarify?
Yeah, so I'll comment on that. And I think you're quite right. I mean, one of the biggest gifts I feel like I can give to women is when I get to see them before. And, the thing that I think actually helps the most with that is, one, I think when we actually have that tactile proprioceptive feedback on a tissue, the responsiveness of it is always better, right? Even if you just think of the discipline of something like therapeutic touch, which there's a lot of substantiation to that. The trouble with our pelvic floor is it's the only muscle in our body we can't touch, we can't see. Right? So, I think because of that, it's an area of massive dysfunction. I think that's one reason why it's an area of a lot of dysfunction. Other areas of our IT band is tight or sore, we can kind of roll it or massage it, or, our pelvic floor, we can't do that. And so sometimes it's even just that therapeutic touch, that interaction for that feedback that allows the nervous system to almost have a Control-Alt-Delete and reset and be like, oh. So I would say I'm usually not doing anything really complicated and sophisticated when I'm checking the pelvic floor, but I'm highlighting, see this, how it's sensitive. And to me, it should feel like a steak that's medium rare, and it actually feels like it's well done. That's how I'll explain it to someone.
Right.
And I'll say, so it's a lot sort of more upregulated than we want it to be, and therefore it's not going to be as optimal for you. What I want you to do is try to connect with where I'm touching and give that part of your body permission to let go and to turn off. You don't need it protecting you. You can tell yourself, it's a bit sore, but you're safe. Cultivating that sense of safety. And immediately the pelvic floor will relax. And I'll say, see? Does it feel different to you? They'll always say, oh my God, yeah, it doesn't even hurt anymore. And I'll say, so I actually didn't even do anything. That's you. Right? But now you're aware and you can get it that you actually have a lot of power over this part of your body now that you're aware. You're aware of how to relax it. You're aware that it's overprotective. You're aware that you have to cognitively send a signal of safety to let it go. But you have that. So you can trust your pelvis more. You can trust birth more. So really, if someone can go into sort of end-stage pregnancy with some pain, but have a better sense of the power they have over it and the control of their own body, and then be going into a birth situation, trusting the birth process a lot more, because now they get this, they do so much better. They do so much better in their birth.
Yeah.
Right?
Yeah.
And then they do better after, a better birth, a better recovery, a better everything. Right? So that's really, I think, the magic of what pelvic health can do for one visit before you birth. Yes, it can help to really get them to really understand how to get the tension out of their pelvic floor. Yes, it can help you verify that as they exhale and think they're engaging their pelvic floor, they actually are doing that well. They're not just doing a squeeze, they are doing a gentle lift, and they are having it timed in a way that's appropriate. Of course, these are all, I would say, collateral benefits. Absolutely. But I think the most important thing is to highlight to someone what's happening in a part of their body that they otherwise don't have a way to get any insight in. And then suddenly they have more ownership over that, right?
Yeah.
To me, that's the most important thing. So I would say the more people can kind of, have that opportunity, the better. But for those who can't, it doesn't mean that all is lost. There is still a lot of benefit that can come without having that.
Yeah. And so we've focused right in on really prenatally, postnatally women. Do we see pelvic girdle pain in men as well?
So pelvic girdle pain, yes, we do, but it's different than pregnancy-related pelvic girdle pain. And so pregnancy-related pelvic girdle pain, this is the one that we see related to a previous traumatic birth. This is the one that we know there is some hormone influence to. This is the one where the study in 2015 showed more widespread hypersensitivity in the whole body when a woman's pregnant. So, pelvic girdle pain, I would say probably does have more of a mechanical component to it than pregnancy-related pelvic girdle pain, which I would argue has more central mechanisms at play. And do men end up with pelvic girdle pain? Sure. How much more is that than women? I don't know, because a lot of studies don't necessarily, if they're looking at men and women, don't necessarily single out pregnancy-related pelvic girdle pain, which can be up to a year postpartum. So even those studies that don't include pregnant women looking at pelvic girdle pain, some of that we might, with a deeper look, classify more as pregnancy-related pelvic girdle pain.
Right.
But men have pelvic floors too. Men get hypertonic pelvic floors too. Men can get upregulation in their system, and we do know that a lot of back and pelvic pain in general does implicate a tight pelvic floor. Myself and Carolyn Van Dyken published a study on this that was published in 2017. And really what we looked at was men and women presenting with any form of lumbopelvic pain, so pelvic girdle pain or lumbar pain, to a regular physiotherapy clinic, so not a pelvic health clinic, a regular physio clinic, just with sort of what they termed as like some form of pelvic or back pain. We then did, if they were enrolled in the study, a whole battery of assessments on them, but one of the things was actually an internal pelvic floor exam. And what we found was that over 90% had pelvic floor dysfunction of some kind, and 87 of those, it was high-tone pelvic floor, even in the men.
Right.
So
it'd be
we know
great
that
if
this high tone is implicated, so that's another paper I can send along to if your listeners are interested. Yeah.
And so backing up to the pregnancy-related pelvic girdle pain, if I'm a yoga teacher and referring to pelvic floor physio, should I also have on hand, I do this, but I want to ask for our listeners, should I also have on hand a referral for a therapist, like a counselor, a psychotherapist, or someone who can dig a little bit more into, like, I know that some physiotherapists do this, pelvic floor physios, but it doesn't always happen. So I feel like on that team, should I have someone who can dig into the trauma side of this? What's going on?
Yeah, I think it's not a bad idea. Certainly, I'm really lucky at the womb where I work because we have psychologists and social workers and counselors. And, one of my team members in particular, really an area of expertise for her is birth trauma.
Wow.
And, and so, yeah, I'm quite lucky as I'm unearthing this, and it really seems like, wow, what's going on here, needs a degree of resolution for you to make peace with this beyond what I'm going to be able to do, then yeah, I can make that referral. So I think it is probably helpful to have that on hand, but probably it can be a little bit safer sometimes to talk in terms of mechanics, right? And I think that's why, health professionals tend to almost go there first, even sort of to a fault. And that's why I think sometimes it can be helpful to kind of indicate, well, look, if you go to a pelvic physio, these are all the things they can do. And also if they identify that there's kind of things that are really outside of their scope going on, they're usually sort of integrated with other providers. So, you could certainly preface it that way. And then when you send off to physio, make sure the physio was aware that you're thinking that they might need something else. Or if you were able to kind of engage in a deep enough conversation with someone and they were kind of saying to you, come hell or high water, am I going to a pelvic physio? But definitely I do acknowledge that there was a lot of trauma. The fact that you're saying that this is probably implicating my current situation, I'd be willing to talk to someone about that. Absolutely, that would help. So yeah, armed with kind of these different resources, I think is always helpful.
Yeah. Okay, that's fantastic. I really appreciate you covering this. Is there anything else that you feel would be helpful for yoga teachers if someone is coming to them with pelvic girdle pain? Any other?
Yeah, I guess one thing that that I would say is, there have been some really well-meaning OBGYNs who have sent patients to me for this problem and have really talked in terms of this language of stability exercises. And I mean, to a certain degree, I don't fault them because the most recent clinical practice guidelines for obstetricians and gynecologists were published in 2003. So really, really old. Like they definitely need an upheaval. But in fairness, at that time, what is a grade 1 recommendation, so really high evidence, is that all patients with back or pelvic pain in pregnancy should see a specialized physiotherapist for core and stability exercises. Ooh. So that terminology was used in that document all those eons ago. There are also other studies, even published as recently as last year, that use the term stability exercises when really what they mean is motor control exercises. And so those are two terms that are sometimes used interchangeably. And I really think we need to get the word stability and stability exercises completely out of our vocabulary when it comes to pregnancy-related pelvic girdle pain. We do not want to be cultivating a perception of lack of robustness in this region of the body. It certainly is okay to communicate, look, muscles that are holding tension and protective don't work very well. So if they don't work very well, they're not going to sort of coordinate well with their other friends in the sandbox, right? So, we do want to cultivate better core control, better synergy, better motor control. I think all of those terms are fine. And I think a lot of the times in these studies, what these researchers have done is actually motor control exercises or looking at kind of the core 4, but they're using a descriptor that really flies in the face of some of these other things. And, I'm really happy that the most recent clinical practice guidelines for pregnancy-related pelvic girdle pain for 2017 have acknowledged that. Like, yes, a variety of different sort of exercise and movement protocols have been shown to be helpful. Not one specific thing more than another, but definitely stability exercises in their traditional sense, which is more kind of the external stabilizers, are not effective. So we do not want to be talking about stability exercises or doing stability exercises, but, doing motor control exercises, which some people might have been calling stability exercises, they need to start calling that what it is.
Right.
So that would probably just be my last point is right. I think all of us, as we're going to be working with people who have been interacting with different people along the way, who are going to have certain beliefs and are going to be using kind of certain language. And language is important because it does have a way of impacting our brain and does have a way of then impacting our body. So I do think we need to sort of be mindful about what words we're using, right? When it comes to this issue. But that would probably be the last thing I would say. I think we were able to cover everything else, which is great. And I'll certainly send you those resources for your listeners.
That's amazing. Thank you so much for your time and your enthusiasm about this.
Great. Thank you again for having me. And as I said, I really think just this little bit will be enough to really make a big difference in the lives of the women that all of your listeners work with. So thank you.
Thank you. And if people want to work further with you, how can they find you? What's the best website to use?
So the best website is the womb, www.thewomb.ca. And you can see sort of my profile there. I'm really receptive to people reaching out to me through email too. And it's dr.Sinead, Sinead, at thewomb.ca. So that's probably the easiest place is through the womb.
All right. Thank you so much, Sinead.
Great.
Alrighty, connected yoga teachers. How is that? So much information. I know this is an episode that you could easily go back to and re-listen. I have already begun to use this information to inform my yoga classes or the one-on-one time when I work with people who are dealing with pelvic girdle pain or also low back pain as well, to just get into some of the key takeaways. Pelvic girdle pain is pain that presents under the rib line, Dr. Sinead Dufour said, to the gluteal fold, so under the glute muscles and where that becomes the leg. And pregnancy pelvic girdle pain is that same place for the pain, but this is just during pregnancy. Something I have really tried to share with different yoga students that I work with and even wrap my own mind around is that trauma to the symphysis pubis joint, that joint at the very front, it's that cartilage joint at the front of the pubic bone, trauma to there is really rare where things are actually coming apart, but sensitivity there is very common, especially during pregnancy. Laxity increases in pregnancy to all the joints and tissues, but I was surprised to learn from Dr. Dufour today that this hasn't been linked to pelvic girdle pain from the research that has been done to this point. And I've heard other experts say this as well. I listened to a pelvic health podcast, and same thing that they're saying is that they're not showing that research, but we are seeing that women have a generalized hypersensitivity during pregnancy in their body, so they're feeling this more. Also, I love to let students know how strong the pelvis is. So I bring my pelvic model around to classes, and as Dr. Sinead says, it's one of the strongest places in our body. If women have had a previous pregnancy, the delivery or pregnancy was viewed as traumatic, there's an increase in sensitivity. And I see this with the people that I work with. And the most important thing I can do as a yoga teacher, I feel, especially when I'm working one-on-one with someone, is to ask them questions. So ask many questions and get into like, when did that pain start? And let them draw the connections there. And also, as I said in this interview time, I definitely refer out when I feel like it's out of my scope of practice to work with someone. The wording, I feel, is an empowering thing. If we can keep giving the language around the pelvis being strong and sturdy, and also adding in that piece, and this is what I wanted to really ask Dr. Sinead today, is what about those asymmetrical movements? What about when we're moving into Warrior 1 or Warrior 2 and many of the poses that we do in a yoga class when one foot is kind of moving in a different direction than the other and we're not keeping the pelvis in that alignment? And I think the most important thing is to let go of the fear of movement. Many of our guests have said this on the podcast. I really come back to Trina Altman, who spoke about this. I know also Shelley Prosco really talks about this, that we need to take the fear out of our language. We're actually going to have Shelley onto the podcast talking about that at some point. But our language, if we can let go of the fear of hurting our students, let go of the fear of movement, but to remember to move mindfully and listen to what the body is needing in this. So understanding that certain movements will aggravate a sensitive and protective pelvis. I use this language all the time now when working with people with pelvic girdle pain, sensitivity and protection, a sensitive and protective pelvis. And to empower this movement for a sensitive pelvis, how can we facilitate that as yoga teachers? A really great example of this is Dr. Sinead Dufour talked about that reverse sit up to lie down, how it irritates that pelvis, and it's also not great for the linea alba tissue if someone has recently had a baby or is pregnant. Again, in the show notes, she has a full document for us to go over how to move from sit to stand to rolling over and any of the asymmetrical movements that we might do. Two things that were really new to me, and these are kind of my key takeaways to think on. Dr. Dufour said, when a pelvic floor is fit, birth is better, and fit is not protective. So I feel like I know this logically, and I need to keep thinking about how I can take that information and use it when working with yoga students. And then also what was really new to me was this idea of removing the word stability out of the vocabulary when we're talking about the therapeutic movements that we're doing with yoga students. So that was new. And that I'm really going to think about. I wonder if some of you use the language around stability and how you see that working with your students, or if you've taken it out, or if you have other language that you use. I'm really fascinated by the language that we use and how it impacts our own practice. So it's the language that we use in our internal dialogue that's going on, and then also the language that we share out with yoga students. And I don't want you to be afraid. We learn as we go as yoga teachers. I know that there are things that I used to say as a teacher that I have changed and modified and learned as I went. That's really the only way you can do it. It's like parenting. You do not know what you're doing until you're in it with each individual child. So just take it easy on yourself, learn a little bit. And this is what this podcast is great for, is that you can just take in little drips of information and just choose, what's the one thing that I'm going to focus on this week? And so with that, Dr. Sinead Dufour asked us to remove the word stability and then replace it with words like language around better motor control. And so this is a piece of work for me. I don't know that I have the language around that. And it feels like it's moving more into language that we would hear from a physiotherapist. So I'm going to do a little more exploration around that. If you have some tips around that, I would love to hear from you. As many of you know, I offer a Yoga for Pelvic Health 20-hour in-person course, and the next one is coming up soon. It's happening September 22nd and 23rd, 2018. Even though it's a little ways away, we already have registrants. It's happening in Meaford, Ontario. Yes, for sure, travel in. There's a place to stay there if you want to. This training includes 20 hours of in-person training, a comprehensive manual, information, and yoga flows to really set it up so that you feel very confident to work one-on-one with people who have pelvic health issues, or to teach a big 12-week series for people, or to add it into your weekly classes that you already have. So go to theconnectedyogateacher.com, look for trainings and events for more information. Also, if you can't make it in person, there is an 8-hour online training for those of you who can't travel or need to do it at a slower pace or have less time right now. Many of you have taken the 8-hour online training, then come to the in-person training, and so you can also decide to do them both. I'm getting some amazing feedback from you guys who are doing the 8-hour replay version. If you do go to sign up for that, please know it is kind of old school how I'm doing it right now. You sign up, you pay, I see that pop into my inbox, and then I send you an email. So it's not like touch the button automatic, but what I like is then each person gets a personalized email with all of the links there, and when things are added, I can update it. So it's the best system for me right now. And that also means that sometimes you're left waiting for, part of a day, or if it's over a weekend, maybe a full day. If you want to work one-on-one with me in a consultation call, visit theconnectedyogateacher.com and look for the Work with Shannon at the top. If we've never worked together before, you're going to look at booking the 90-minute initial consultation call. If we have worked together before, you already know the drill. You can book a 1-hour follow-up or a package. You have both options. What would be really sweet if you are enjoying the podcast, you are loving the content, if you could please go and leave a review, either on our Facebook page, look for the Connected Yoga Teacher, or in iTunes. And if you're not sure how to do that, you can go to any of our show notes pages and click on the leave a review button. I love to read your reviews. I often read them out on the podcast, so you might hear your review read out in a future episode. Today's episode is possible because of our dynamite team. Thank you to Laura, Samantha, and Suzanne. Stay connected, connected yoga teachers, to self, to your practice, and to your community so that you can share the yoga that lights you up.